Hello, this is Jennifer Alban, and we are going to be talking about case study number 2 from the osteoarticulations module. I'm going to be proving the hypotheses that visual disturbances caused by migraine auras can be reduced or eliminated using visual synkinesis as treatment. This case study was chosen due to an interest that manifested when visual synkinesis was introduced in the osteoarticulations module. We as manual osteopathic therapists are taught to use principles of osteopathic when we are treating and assessing clients. Being that the body works as a whole, the idea that we can use different parts of the body to treat a specific part is the idea that I am bringing into this case study. Eliminating visual disturbances caused by these migraines would be a huge benefit to the client and allow the client to be able to manage the migraine that is either developing and hopefully stop it in its tracks. This would provide additional ability to properly care for the migraine, as well as the ability to see correctly during these episodes. So, what is visual synkinesis? Synkinesis has been described in a few different ways after some research has been done. Nelson Kwong Lun Lai describes synkinesis as the abnormal contraction of muscle during volatile movement of another muscle. This definition was used, like most others, in terms of pathology and used in examples such as Bell's palsy. By using the word abnormal, it is assumed that the involuntary action is unwanted. In the case of Bell's palsy and other facial nerve pathologies, it may be unwanted, but for this case study, we want to use the connection between the somatic and the autonomic nervous system via the eye movement to help reduce those visual disturbances. So for this case study, a more appropriate definition would be that of Monique Ryan and Elizabeth Engel. They describe synkinesis as an involuntary action of one or more extraocular muscles associated with voluntary eye or other movement. This typically results from aberrant innervation. So this definition creates more of a dynamic for what we are trying to accomplish during this case study. We are using the voluntary eye movements to manipulate the contraction and relaxation of the other surrounding muscles, nerves, and blood vessels, creating a more balanced and homeostatic state of the eye. So people who suffer from migraines can suffer from auras. Migraine auras are the sensory symptom that can occur before or during a migraine episode. And visual signs can include zigzag lines, blind spots, stars, spots, changes in vision, sensitivity to light, flashes of light, and color wheels. Informed consent was read out loud to the client as further strain to the eyes was not encouraged, and I did not want to aggravate my client's symptoms. Signature was received on and consented after all was discussed and understood. The decision to treat my client was made because of the state she was in, and it was not going to affect any of my current or future appointments. Or cost any additional in supplies or travel. In fact, it was a benefit for the simple fact that research needed to be conducted for this study, and it was an opportune time to come in. Accepting the client as a walk-in was also a benefit to the client, as treatment was intended to reduce discomfort and disturbances during the episode of a migraine aura. This treatment was only effective during that time, and typically these auras are only lasting between 20 and 60 minutes. This was a judgment call that I made to take her in at that time, and I believe it was a beneficial call for both me and my client. Client ES is a general healthy 25-year-old female who has been experiencing migraines for most of her life. She always experiences migraine auras prior to the head pain, and this happens roughly once every few months. Client mentioned that she notices they start to happen in high times of stress and anxiety in her life. She was experiencing a migraine on a midday in May, and this is when we decided to treat her. She is currently on antidepressants and anxiety medication and has been for about 5 years. She feels as though they are quite regulated and have been doing positive things for her. She has been experiencing migraine auras more frequently, and sometimes it is not even accompanied with head pain, just the eye disturbances. She feels she is depleted of energy as she comes in today. Visual disturbances have occurred starting in the lateral portion of her right eye. Shortly after, there was kaleidoscope colors in the lateral portion of her left eye. Typically, this is the same pattern every time, and these visual disturbances will start to spread into the center of her eye, and eventually she needs to just lay down and close her eyes because she cannot see any longer. Residual flickering and light specks happen for a few days after these visual disturbances. These episodes typically last from 20 to 60 minutes, and it is always followed by stiffness and tenderness within the posterior aspect of her neck up into her suboccipitals. Her eyes feel strained for days after her visual disturbances. They feel as if they are working harder to see, and they feel strained. Client is an avid coffee drinker, up to 5 cups per day, and she believes that this could be a cause of her migraines sometimes, or if she has lack of coffee, that she notices her migraines will start occurring. Head pain usually follows an aura about 40 minutes after the visual disturbances if they are to come. Client noted to have prescribed eyeglasses. She wears them all of the time as she needs them full time for work. So some biological determinants that were notable and relevant to the migraines and the auras was the amount of coffee to water ratio per day, the medications for the depression and the anxiety, and the chemical balance that may be happening within. Physical body changes from the shifts postpartum. She is a mother of a 1.5-year-old who had previously done IVF treatments to become pregnant. Some psychosocial determinants that were notable. She is a highly stressed person. She does experience panic attacks and anxiety attacks often. She has been on medication for 5+ years and just recently feels as though the medication is working for her. Also, the new stresses of a new motherhood. This is her second child and it is a new adjustment. We are also all facing a global pandemic at the moment, and this is during the first year of her child's life, and it has caused more stress than she was anticipating. So I'm going to show you some slides of what I found during my Mitchell structural test. When the client arrived into my treatment room, she was extremely potentiated. The decision to put her into the Jones technique position was made. She was instructed to lay onto the table in the most comfortable position that she could be in. We bolstered her and pillowed her. I then located the most point of tenderness within her neck, which was at her suboccipitals. We then moved her into further extension where she was relaxed. I had then asked her to close her eyes and keep them closed and allow herself to relax for 90 seconds. After 90 seconds, palpation of the neck shown that there was not much results. So we continued to use this technique for 2 more minutes in full relaxation with slight extension of the neck. After 2 minutes, palpation showed that there was more pliability and less hypertonicity within the suboccipitals. She did note that her eyes felt less strained, and visual disturbances were the same, but they did not feel as though her eyes are tensing as hard. This technique was chosen prior to this assessment and treatment because of how potentiated the client was when she arrived into my treatment room. She was experiencing slight lightheadedness, and visual disturbances had already begun. She was also feeling very sore in her posterior neck. Client's eyes closed the entire time was a necessary step in this process, as I wanted to provide optimal relaxation of the ocular muscles. By definition, this technique is relieving pain by reduction and arrest of continuing inappropriate proprioceptor activity. This is achieved by shortening and relaxing the muscles that contain the malfunctioning muscle spindles by applying mild strain to the antagonist. In other words, the inappropriate strain reflex is inhibited by application of the counter strain. Having the client's eyes closed the whole time was where we chose to have optimal relaxation of the ocular muscles. In the chapter of Jones' technique in our osteopathy textbooks, he also mentions that it would appear in the long term a somatic dysfunction creates a sensitization of the reflex neural circuits, and so often after restoration of normal function, this memory of dysfunction remains especially susceptible to insult and may result in the resensitization. It is for this reason that Jones found by experience that the return of the normal position had to be gentle, and it was good practice to advise the patient to take it easy for a day or so following the treatment. So using this advice, we slowly allowed the client to come out of that relaxation position, have her eyes closed, slowly open them up, and come back out of position after about 10 minutes post-relaxation after applying this technique. A global assessment was completed with the client. Heel drop was performed, and the client felt heavy in the head and a sense of relief on the neck upon impact on the floor. This found interesting to me. Kaleidoscope colors also immediately stopped upon impact on the floor, but were immediately restored once the client had restored her balance. Relief sensations when side bending the neck either way were felt. An extension of the neck caused more pressure in her eyes, but more relief in her neck. There was testing of cranial nerve number 2 done, and noted that the client was unable to report back the number when we were assessing her from the bottom corner of each eye. The visual disturbances were not allowing her to see what was happening. During the seated neck GOT, this is where we implemented the visual synkinesis into the treatment. This is a very gentle and light technique and requires relaxation and quiet. Having my client seated, I have performed visual synkinesis. Please see this video on how that was performed.
Having my client look down, I have her notice how her head wants to tip forward. Then ask her to look upwards and note how her head wants to tip backwards. I then want her to look at her own ear and notice how her head wants to left and then automatically. I then ask her to look down at her right pocket and notice how her head wants. Now with slight gentle pressure, I am going to apply resistance at her front and posterior head and ask her to look down and resist my pressure at. I then am going to ask her to look up and extend her neck at 10%. Again, we will do this with rotation. having my client look to side bending, having the pockets again. Again, this is with resistance at 10%. This treatment was performed 3 sets with the lights down low. This reenactment was done with the same client, and I did have her permission to have her face filmed here. This was post migraine. We were unable to do filming during the episode. My client has allowed me to film her again and do this treatment study.
After the GOT with visual synkinesis was completed and the client was feeling a overwhelming sense of relief, which is very exciting, we did complete a assessment on the atlantoaxial joint. The client was presenting with a restricted right rotation, only up to 30 degrees. A correction was done, reassessed, and corrected with an AASOT treatment. The OA joint was then assessed and found no restrictions. Post-treatment, speaking with the client, the results were astounding. We were very excited to note that the pressure building behind her eyes had completely halted, resulting in less severe headache post-auras. Her eyes felt less strained the next day, and she had almost no eye symptoms after the first day after her migraine. This client felt that the kaleidoscope colors had become more transparent instead of opaque, giving her the ability to see her peripherals. This was very exciting to hear. For me, this proves this hypothesis true, that we are able to reduce visual disturbances using visual synkinesis. This treatment is great because it can also be done at home as home care, and it is simple as being aware of the function of your eyes and what they are doing voluntarily and involuntarily. My client has been referred to a clinic which would specialize in cranial sacral therapy, as there are people who are much more skilled than I, and I have not reached that skill level in my schooling yet. So I have referred her to somebody that I personally know at a clinic I work at who has astounding reparability for her cranial sacral work. I have also advised and referred my client to go see a general medical doctor to make sure that all of everything else is in balance and in tune and in check. Because it is not a known reason or cause for migraines, there shows a large gap in where we can develop treatment. This seems to be a trial and error basis and is very individualized treatment. Visual synkinesis also is a principle that lacks research or seems to be used as a negative connotation paired with Bell's palsy. I believe that more research could be done to use this connection between the somatic and autonomic nervous system as a benefit to treat other parts of the body. This has been a very, very exciting case study to do, and I'm very happy to have been able to prove this case study true. Thank you so much. During this case study, the short-term goals were absolutely accomplished, and that was to reduce the visual disturbances and discomfort of my client. I am happy to say that that was successful. The long-term goals is now for my client to be able to practice this on herself when she is starting to experiencing these migraine auras. This would significantly help her in the risk of being stuck where she is. If she starts experiencing these auras, she may be able to diminish or relieve these in time to be able to get to a safe place. where she can rest. After all of the research and time put into this case study, I have found it extremely exciting and innovative. The results found after this treatment were not only shocking to myself, but to her. This is something that I'm absolutely going to implement into my practice. As a personal sufferer from migraines, I am going to use this on myself. I'm going to teach anybody that I know to. This is very exciting, and I am happy to have been able to prove this hypothesis for this case study. Thank you all for watching.